ينادي يا سنا الفجر
وينبوع الشذا العطري.
Good day, everyone. My name is Dr. Haitham Mekkawi. Welcome to this teaching session on the recognition and management of cardiac trauma. Cardiac trauma is one of the most challenging and time-critical emergencies in anesthesia and critical care. It can present silently or with catastrophic collapse. In this lecture, we will explore the mechanisms of injury, the early warning signs, and the immediate interventions that save lives. Let us begin. Cardiac trauma refers to penetrating or blunt injury to any cardiac structure, including the myocardium, the pericardium, the coronary arteries, the conduction pathways, or the great vessels. It is most commonly associated with road traffic accidents, high-velocity penetrating injuries, crush injuries, and blast trauma. Patients with cardiac trauma can arrive with very subtle symptoms or in profound shock. Common findings include dyspnea, tachycardia, and chest pain. In severe blunt trauma, you may also see flailed chest, bruising, or distended neck veins. Always have a high index of suspicion. Clinical presentation. Cardiac trauma can present with a wide spectrum of symptoms. Some patients arrive fully conscious, while others present in profound shock. Common early signs include dyspnea, tachycardia, and chest pain. These symptoms may seem nonspecific, but in the context of thoracic trauma, they must raise suspicion immediately. More severe presentations may involve hypotension, muffled heart sounds, or jugular venous distension, indicating potential tamponade or massive cardiac injury. Always remember, the absence of dramatic findings does not exclude a life-threatening cardiac lesion. Pathophysiology. Blunt cardiac injury requires substantial kinetic force. Rapid deceleration can produce myocardial contusion, tear the coronary vessels, or impair ventricular function. A direct precordial impact may rupture the myocardium or damage the cardiac valves. Compression of the heart between the sternum and the spine can lead to chamber rupture with immediate hemodynamic collapse. Penetrating trauma delivers a focused insult, often lacerating the myocardium, the coronary vessels, or the pericardium. These injuries frequently result in acute pericardial tamponade, rapid blood loss, or catastrophic circulatory failure. The consequences of these mechanisms may include myocardial contusion, coronary artery laceration, acute pericardial tamponade, ventricular septal rupture, valvular disruption, arrhythmias and conduction block, and in the most severe cases, complete cardiac rupture leading to pulseless electrical activity. Differential diagnosis. When assessing a patient with chest trauma, it is essential to widen your differential. Many life-threatening conditions can mimic one another in the early stages. Pulmonary contusion and myocardial contusion are frequently seen after blunt thoracic injury and may present with dyspnea, hypoxia, or chest discomfort. Pneumothorax or tension pneumothorax must always be considered, especially when there is respiratory distress, tracheal deviation, or sudden hemodynamic deterioration. Cardiac tamponade remains one of the most critical diagnoses to identify, particularly when hypotension, muffled heart sounds, and distended neck veins are observed. Myocardial laceration and coronary artery laceration may produce rapid blood loss, arrhythmias, and circulatory collapse. Esophageal rupture and traumatic dissection of the thoracic aorta are less common, but carry extremely high mortality if missed. Diaphragmatic rupture should also be considered, especially in blunt trauma with abnormal breath sounds or abdominal organ displacement. Myocardial contusion can lead to significant arrhythmias and hemodynamic instability, even when external signs of trauma appear minor. A systematic and structured approach is vital because the correct diagnosis directly determines the life-saving intervention. Immediate management, ATLS, and anesthesia priorities. Management of cardiac trauma begins with the primary survey, using the principles of airway, breathing, and circulation. For the airway, secure it early when there is reduced consciousness or significant respiratory distress. Delayed airway control may lead to complete collapse in patients with evolving thoracic injury. For breathing, treat pneumothorax immediately. If tension is suspected, perform rapid needle decompression, followed by prompt insertion of a chest tube. Circulatory management must be decisive. Establish large bore intravenous access. Initiate balanced blood transfusion in a 1:1:1 ratio when hemorrhagic shock is present, and perform pericardial decompression without delay when cardiac tamponade is suspected. If cardiac arrest occurs, prepare for emergent thoracotomy. High-flow oxygen should be provided to all trauma patients to optimize oxygen delivery. Activate the thoracic and trauma surgery teams early because many of these injuries require operative repair. Prepare for chest tube insertion and prepare for pericardial decompression using either the subxiphoid approach or ultrasound guidance. Emergency thoracotomy is indicated in penetrating trauma with loss of vital signs within 10 minutes or in blunt trauma when there are clear signs of life. Cardiopulmonary bypass may be required for definitive cardiac repair when major structural injury is identified. Supportive management is equally important. Provide fluid resuscitation and vasoactive support as needed. Initiate mechanical ventilation when necessary, but avoid excessive positive pressure ventilation before decompression of pneumothorax or hemothorax. Provide early analgesia to reduce sympathetic surge, and maintain continuous electrocardiographic monitoring to detect evolving arrhythmias. Diagnostic evaluation must be rapid and targeted. A chest radiograph may reveal a widened mediastinum, pneumothorax, or hemothorax. Computed tomography of the thorax can demonstrate myocardial contusion, pericardial effusion, or vascular injury. Bronchoscopy allows assessment of the airway and lung for associated injuries. Esophagoscopy helps rule out esophageal rupture in complex thoracic trauma. Transesophageal echocardiography is invaluable in the operating room and the intensive care unit. It detects wall motion abnormalities, valvular disruption, ventricular rupture, pericardial tamponade, and injury to the aorta. Subsequent management requires close and continuous collaboration with surgical teams. Thoracotomy or sternotomy may be needed to repair structural cardiac or thoracic injury. The tracheobronchial tree must be fully evaluated, and lung isolation may be achieved with a double lumen tube or bronchial blocker in patients with significant pulmonary injury. Ventilation strategies should be optimized to prevent further damage to the injured lung. Hemodynamic management includes the use of vasopressor and inotropic support, guided by continuous monitoring. Serial echocardiography is essential to assess myocardial function and to track recovery or deterioration after the initial insult. Diagnostic studies. Diagnostic evaluation in cardiac trauma must be rapid, systematic, and highly focused. A chest radiograph is usually the first investigation. It may reveal a widened mediastinum pneumothorax or hemothorax. Computed tomography of the thorax provides a more detailed assessment. It can identify myocardial contusion, pericardial effusion, and major vascular injury. Bronchoscopy is extremely valuable when airway or lung trauma is suspected. It allows direct visualization of tracheobronchial injury and helps guide management. Esophagoscopy may be required to rule out esophageal rupture, especially in severe blunt thoracic trauma. Transesophageal echocardiography is critical in both the operating room and the intensive care unit. It can detect wall motion abnormalities, valvular disruption, ventricular rupture, pericardial tamponade, and injury to the aorta. Together, these studies help define the extent of injury and guide immediate life-saving decisions. Subsequent management. After the initial stabilization, subsequent management focuses on definitive diagnosis and surgical decision-making. Continuous consultation with the surgical teams is essential. Many patients require thoracotomy or sternotomy to repair structural cardiac or thoracic injuries. A full evaluation of the tracheobronchial tree is necessary because airway injury may coexist with cardiac trauma. If significant pulmonary injury is present, lung isolation can be achieved using a double-lumen endotracheal tube or a bronchial blocker. Ventilation should be optimized to protect the injured lung, avoiding excessive airway pressures and maintaining adequate oxygenation. Hemodynamic support often requires vasopressor or inotropic agents, guided by continuous monitoring and the patient's response. Serial echocardiography is valuable for tracking myocardial function and detecting evolving complications. Special considerations for anesthesiologists. Anesthetic management in cardiac trauma requires constant vigilance and an understanding of unique physiologic risks. First, nitrous oxide must be avoided. It can rapidly expand an unrecognized pneumothorax, leading to hypoxia and cardiovascular collapse. Second, be alert for tension pneumothorax, especially during one-lung ventilation. A sudden fall in oxygen saturation, rising airway pressures, or hypotension should immediately raise suspicion. Third, always expect some degree of cardiac involvement in blunt trauma. Continuous electrocardiographic monitoring is required, with awareness of arrhythmias, such as premature ventricular contractions, ventricular tachycardia, or atrioventricular block. Fourth, induction carries a real risk of hemodynamic collapse. Ketamine is often preferred because it maintains a sympathetic tone, while etomidate may be selected for patients who are profoundly unstable. If cardiac tamponade is suspected, maintain spontaneous ventilation until decompression is achieved. Together, these precautions ensure safer anesthetic care and significantly improve outcomes. In summary, cardiac trauma is a time-critical emergency that demands rapid recognition and decisive action. Begin with the ABCs of trauma care, ensuring airway protection, effective breathing, and circulatory stability. Maintain a high index of suspicion for tamponade, myocardial contusion, or great vessel injury, even when external signs seem minimal. Use TEE, Connecticut imaging, and chest radiography to guide diagnosis and involve surgical teams early. Definitive management may require operative repair, aggressive monitoring, and coordinated critical care support. With prompt intervention and careful anesthetic management, survival outcomes improve significantly. Thank you for your attention. Thank you for watching. If you found this lecture helpful, please don't forget to hit like, share it with your friends, and subscribe to our channel for more educational content. And if you'd like to explore more lectures, clinical notes, and recorded courses, you can always pay us a visit at our website at anesthesia.sd. Once again, thank you for your time and support. Then I look forward to seeing you in the next session.